Okay, that was wonderful. Please join me in thanking our panel again, and also for keeping on time. So we are on time, which means we have about 20 minutes for questions.
And I carefully walked up to the microphone to be the first one in line. Thank you for that. That was marvelous. And I kind of want to start with the end, Sarah, because you pointed out that the saying is always, if you don't measure it, you can't improvement. Your corollary clearly says that measurement is necessary but not sufficient for improvement, and that's certainly been the case in general. To foster improvement, you either have to have someone who wants to improve because it's the right thing to do, and sad to say there are a few of us that's not as big a motivator as you might think. What other things might we do to motivate people to improve, or to, take these measurements and actually use them to improve the quality of care?
So that's where I actually see the Affordable Care Act is working with us, because there's one piece of this has to be about having a system that's supportive, that it's not on the back of the primary care provider or any individual institution to do this work. We've interviewed primary care physicians, and they said, we're not going to do anything about depression because I don't know any psychiatrists, and I can't make that warm handoff to psychiatrists the way I can make a warm handoff to endocrinologists and to cardiologists for my patients with diabetes and cardiovascular disease. So I do think it's joint accountability, and what I like about models like the shared savings programs, the health homes, the patient-centered medical homes, and the activities incentivizing states and health plans, is that you have to get all the players together to be responsible for it. Improving mental health and substance use care and outcomes is not the responsibility of just that mental health clinician or the health plan. I mean, it really is a community effort, and I'm hopeful that some of those programs are going to do it. Now, it also depends on having the right measures out there. I think one of the reasons why the follow-up after ADHD measure isn't improving and has such a lousy performance rate is that people don't believe it. So I really think if we had an ADHD measure that looked at whether kids are improving on the Vanderbilt, that would have more salience to clinicians. I still hear people say, yeah, but what I really want to know is whether my kid's back in school, my kids are graduating. But I'm sure the Vanderbilt's going to get closer to symptom reduction, something that a clinician has some influence over, than just getting kids in for a visit. So I think those are part of the things. But one of the reasons why we have those follow-up measures that are from claims is because that's easy to do from administrative data, from claims data, and less expensive than all of the huge amount of new data systems, new infrastructure, new workflows that would be required with an ADHD outcome measure. But I actually think under the Affordable Care Act and the investment in health homes and the investment in shared savings, we might actually have more opportunity to improve measures.
Just one additional point. I think, basically we're limited by the sort of the human motivators that exist, fear, shame, and money, and maybe pride. But one of the other problems is that with the profusion of measures out there, that the number of measures that are particular to child or to mental health gets small among the whole market basket of measures. And so that's another issue, is where do you put your efforts that might be limited, and how do you, have some rotational system or something that actually, has meat but is, allows different groups to focus at different times on different issues. The other big piece of it is we're not training our behavioral health professionals about this whole issue of measurement, and both at a clinical level as well as at a systems level, and how to improve.
Thank you. Just a reminder, if you're going to ask a question, please state your name and affiliation for the recording. Thank you.
Hi, my name is Hendrix Brown from Northwestern University, member of the forum. I thought these were 4 great presentations, and really think these are really incredibly valuable for us in our country in here. I wanted to see if we could sort of think into the future about what are the next stages in here, and particularly around issues of incentivizing. What are the kinds of activities for incentivizing health systems to really move towards inclusion of measures that include outcomes? Which I think is the real challenge in here. It's not been tradition, as you folks have been saying in here, but there certainly are ways of trying to use sampling to try to get some additional information about following up. You don't have to follow up every patient, for example, and some stratified sampling kinds of procedures, using technology for collecting information, which we've been talking about as well. When Richard Frank was here a couple of sessions ago, he mentioned off the cuff 3 kinds of sort of steps that health systems might be going through in terms of the review of their quality. One would be the quality of that, giving the existing measures looks fine. Nobody has to do anything in there. They can get a pass or they get a great grade. A second one is if there's a question about that one that may need a little bit more intensive, that the organization should be following up patients a little bit more to collect more information, especially outside their own, health systems in here. So what are the assessments of symptoms, for example? And the third level is one where there would be a penalty. It would be much more intensive. It would cost the system if they did not meet certain grades in here. And so there would be some expectations in here, financial expectations for organizations to really begin to think into the future. We're talking about innovation. Everybody who talks about, the innovation vice presidents sort of think this is wonderful ideas, but it doesn't seem to happen.
Just 2 points about that. One is, I think ultimately you have to build measurement into the processes of care. And because that's actually where, if you look at successful interventions, it's really, and we're talking largely about, things that are not, it's not like appendicitis or otitis media. It really requires that you follow people over time and that you measure outcomes. So this concept of measurement-based care, and that's built into at a clinical level. And then if it's built into a clinical level and you can actually establish things like what's been done in early childhood and patient-centered medical homes, but build that into a behavioral health framework for a structural accreditation process that incorporates within it an expectation of longitudinal measurement that then gets reported as outcomes is the way to go. I think you have to be a little bit careful, though, in this notion. Richard's a dear friend, but you may, unless you have adequate risk adjustment, other kinds of, you may be penalizing those systems that are treating difficult populations. So you need to make sure that you have adequate ways to protect against that.
And I just wanted to add on to that. I really think it has to start from clinical care for the measures to be relevant and meaningful to clinicians. Part of the challenge we have with that follow-up after mental health hospitalization measure is who's really accountable? Is it the hospital? Is it the outpatient? The outpatient people say, oh, I don't know. The hospital says, well, I made the appointment. It's not my fault they didn't show up. So, that's where we say, okay, you're the health plan. You are responsible. So you have to have, people have to have skin in the game. If we measure at the level of the health plan by sampling and looking at scores for some portion of patients, every one of the clinicians is going to come back and say, those aren't my patients, I'm not responsible. That's what we hear from clinicians about breast cancer screening for their patients. They say, those data came from the health plan. The health plan doesn't know what I'm really doing with my patient. So that's another reason for it to be built into the fabric of clinical care. First of all, who's going to do something about that information? It's the clinician. So, but that's not necessarily where the accountability is, and we don't really want every clinician to be responsible for creating the data infrastructure, for choosing the tool, for making sure that there's monitoring and follow-up. There are ways that we can think about those responsibilities of different members of the team, and where it could be the clinician that's providing the therapy. There's a care coordinator that's making sure that the patient is getting the follow-up assessment and reminding the patient to come back into the clinical visit. And so there are other ways to think about that, and we're actually seeing that happening in communities where there are patients in our medical homes and community initiatives around them.
Can I just quickly say, because I do think there are a lot of analogies across the different fields that are doing this in early care and education as well. And a couple of points here. One was that when the quality rating and improvement systems came into place, it was hard to get centers to voluntarily participate. So now states are moving toward, you come in at the bottom level, the lowest. These are star or medal ratings. You know, you go bronze, gold, silver, and so they're doing that so that everyone has incentives to participate. The rating and improvement is meant to partly be marketing, and that's why there are stars and medals. So it's meant to also give information to consumers about making choices, to parents about making choices, and I think that's, you know, an analogy as well. But you know, when I work directly and talk to directors and teachers, there's also concern that it's meaningful to them and that they're part of the process in defining quality.
Hi, Kimberly Hoagwood from NYU. So great, this was great. I have two questions of a different type. The first one is, we're a prevention IOM forum committee kind of thing, and so we're focused on prevention research, and so there's a slew of it, as you know, but much of it is focused on the ecology that surrounds kids, their families, parenting, neighborhoods, communities, etc. It's quite different from the examples that we have right now in the child mental health on follow-up ADHD for medication, or adolescent depression, or the psychotropic prescribing. So I wonder if you could talk about either other examples from other fields of health where the focus on prevention, on risk, on identifying risk can be built in as a performance measure. So that's question number one. Question number two is, it seems to me we're in a conundrum as a field right now because there's clearly the evidence base is a cornerstone from which to develop these performance measures. That's where we start. And yet our funding sources, NIH in particular, is backing away significantly from the development of evidence base around interventions that might be very relevant for, you know, continuing this kind of work. And so I'm wondering how you think about the ways to continue to build the science base and the evidence base in a way that's going to contribute to the development of and testing of these performance measures.
Well, I just, with regard to the prevention issues, I think it's really a basic problem of who's accountable for prevention. And, you know, it's really thinking about how do we apply population health measures in a way that understands what are the sort of the theory of change for accountability in that regard. And, you know, there are some of the elements of ACOs and other shared savings things that can potentially ascertain accountability or specify accountability. But a lot of that accountability is around the costs of the population as a whole. And it may not be, and it's during a particular time period. And so that may bode not so well for preventive interventions for a child group that where the actual overall impact may be less financial in the short term. And so that's one of the key issues in terms of how to think about that. There are other ways in which sometimes there's secondary kinds of things for a population. So in some academic health centers, and ours for example, we've undertaken a lot of initiatives in the community as a way to, in a sense, as a way to reduce sort of unneeded volume in our emergency room and in admissions to our hospitals so that we have more room for more tertiary and quaternary care And so there's kind of a secondary benefit. So we do have an incentive, but it's kind of an indirect incentive for us to implement, various forms of preventive population-based measures, and to think through more, how can you do that? What are the secondary benefits of doing that, if you can't build it in a primary way? In terms of the, the issue about NIMH, I think that, their movement away from testing evidence-based interventions, I think, though, bringing to the fore the evidence that, we're not really applying the existing body of evidence-based measures, and that learning how to do a better job of that, learning about what are the ways by which one can incentivize population-based health measures.
I'll just piggyback on what Howard just said from the perspective of the Department of Justice, is that we're not moving from, our department's not moving away from evidence-based practice and investing in that research, but really expanding and enhancing complementary to that work, how we translate and apply that to the field, that both need to happen. Evidence-based practice takes a long time to cultivate. It takes a lot of money. People at the practice level need to work with the best of what we know now, and how do we bridge the two? So we've invested in a lot of evidence-based work in terms of RCTs, but also the crimesolutions.gov and our model programs guide that looks not just at what's working, but then now what do you do with that information? And to the earlier point about prevention, I think one of the exciting things about the standard program evaluation protocol is that it has application to across the social science field with that robust research, which means we need to continue to cultivate that evidence base. But the prevention field has a tremendous amount of research, taking outcomes and organizing that rating instrument around what we know helps bring all that into one place and allows people to apply those quality indicators to any program. So.
And just piggybacking on this idea of who's the accountable entity, I actually think on this prevention side, if you heard Jeff Schiff, who is just, if you don't know, Minnesota is way out front of where a lot of Medicaid programs are, and but his desire to think more broadly about how what the state Medicaid program is responsible for, and part of the reason he can do that is because that's the different parts of the state are all working together, and I would think that might be a leverage point. We heard from other states and communities yesterday where they're taking this broader perspective. So that's there. It's important to have that understanding at that level of the community where you're responsible and where there's somebody who can benefit from reducing cost in juvenile justice. They can realize the benefit of reduced juvenile justice because you do earlier mental health treatment, identification and treatment. You have to be able to see it both in terms of the time frame and where the dollars end up, right? So I think those would be some areas to think about.
Okay, and our final question.
Hi, Dave Brent, University of Pittsburgh. So one of the things I was thinking about is how to align these competing forces. And one thing that occurred to me is one of the most onerous transformations that happened in the last 10 years is the electronic medical record, which is a huge time sink for most clinicians, and they hate it, almost universally. And I'm just wondering if there's a way to streamline the charting in such a way that you either have some kind of flow diagram that relates to evidence-based care. So you're forced to follow that, click on some things, and include those measures. So the advantage to the clinician is that it would be simpler, and yet at the same time it would constrain their behavior with regard to gathering the evidence. I think if you look at most electronic health records, they're designed with the end user in mind. Like, what's the data that we want to gather in order to do something, as compared to what's the easiest way for the clinician to do their job. And so, I offer that as one possibility. The second point I'd like to make is just that I think there's also a responsibility that patients and families have for quality improvement. It shouldn't just be a top-down process. And I'm just wondering if one of the ways to facilitate that is to make sure that families are educated about the disorder, about the measurement, about, you know, how to advocate for themselves. Because, you know, there are a lot of nuances in the treatment, and you have to be able to provide information to the clinician in order for them to decide that something is or isn't working. You know, things that may go a little bit beyond the measures that we have.
I just wanted to make one comment because your question reminded me again of an analogy. In early childhood, we've seen a move toward using the technology, and there are new systems. The most popular is called Teaching Strategies Gold, which allows teachers to enter information, see where a child's development is relative to typical development, understand where that child's been and headed, and what they could do in the classroom to individualize instruction for that child. And so there's, you know, all kinds of conversation around that. It takes time out of the classroom to fill this out, and may take, you know, away discretion from teachers in thinking about what to do, but it is really leveraging the technology, a lot of interest in where that's headed, and sometimes embedded in there feedback to parents as well that can make it more meaningful.
So your comments about the EHR are really apropos, and unfortunately, you think that it's designed for the end user and the data coming out, but frankly, it doesn't work for us either.
Well, I think part of there shouldn't be an us and a them, but
right,
aside
but
from that.
It's, you know, in terms of quality measurement, we thought, well, the EHR is really going to make it so much easier, and frankly, it doesn't. It's much harder. But I actually think your second point about engaging patients and adolescents and families.
Well, wait, so what do we do about that? Because shouldn't leave that so easily.
Yeah, so I'll get to that.
Yeah.
So I actually think there is a lot of work to be done to use make the EHR systems more usable, both on the front end for the clinician care, for the clinician and the care team. But a big part of that is really rethinking who should be doing what within that system. And so that it's not, so some pieces of that documentation can be done by other members of the care team. Despite all the certifications of EHRs, they don't really get at the usability of the systems for the functions. There is a desire to have clinical decision support embedded in those systems, but how do you do that? So I think right now our whole model of the EHR is based on the EHR sitting in the clinician's office, rather than thinking about that as being an electronic interface to clinical decision support, and also an electronic interface where patients and families can put information directly in. So it's not the clinician recording it or a care team member recording it, but it's a way that there's information that could come into it from patients and families, particularly on these kinds of symptom response scales or functional status issues, if you had a way to do that, and that's actually what we're going to be testing.
David, I think your assumption is going the wrong way. That actually it shouldn't be the electronic health record that's sort of countermanding workflow. That you first have to figure out, how do we redesign workflow to establish this sort of measurement-based care, and then build an electronic record around that. And
I was assuming we knew, I guess.
Yeah, but I think that's really the way it ought to go.
Yeah.
And I think that you know, and Sarah's absolutely right that, you know, that whatever does come out of it should be not just usable for clinicians, but usable for patients and parents as well. And so I think that's an important piece of it. The Office of the National Coordinator for Health Information Technology actually is working on developing standards for behavioral health EHRs, and it may be worth, you know, sort of talking to them about that. Also, the National Partnership for Women and Families, you know, is also sort of working with ONC on some of this stuff, and, you know, thinking about how this sort of patient-family portals can, you know, actually be utilized more effectively.
I just remember a friend of mine trained in Israel in psychiatry, and he didn't know Hebrew very well. So he had the patients write the notes. And I thought, it accomplished a lot of things, It shortened his workload, and the patients wouldn't quarrel about what was in there. And, it created a more open process. So maybe there's something to that.
I think that's a great place to end. Again, thank you to our panel, and I think we have a break now.